Okay, well, I think we'll make a start because it's just gone, it's 5 minutes after the hour. I hope you can see my slides. If you can't, just please let me know. Well, welcome everyone to today's paediatric teaching. And today I thought we'd talk about failure to thrive. We often talk about failure to thrive in different terminology. We sometimes just call it severe malnutrition or severe acute malnutrition, or these days SAM or MAM, moderate acute malnutrition. But today we'll just talk about failure to thrive because it's an all-encompassing term, I suppose, that includes severe malnutrition, but also an understanding of the mechanisms, both physiological and psychosocial mechanisms of failure to thrive. And it also encompasses not just the physical nutritional aspects of failure to thrive, but also the developmental aspects of failure to thrive. So I think it can be a useful term, but it's not dissimilar. It's very similar to severe malnutrition or SAM. When we think about children failing to thrive, it is one of the most common presentations for children to hospitals. And sometimes children present with failure to thrive, but more often they present with some other a symptom and sometimes some other disease. But you notice as the doctor looking after them that they are failing to thrive, and that can tell you something about the severity of their physical condition, and it can also tell you something about the duration of the condition and the nature of the condition. So when we think about failure to thrive, we should think about what the possible clinical etiologies are and what the possible mechanisms are. All right, and so these are broadly speaking, the clinical etiologies. So of course, some children have primary malnutrition. That is, they've just been starved. Other children have chronic illnesses as a cause of their failure to thrive. It could be chronic respiratory or cardiac or renal or gastrointestinal, some sort of chronic illness or chronic infection, and that leads to failure to thrive. It could be a relatively simple illness too, such as a urinary tract infection that's not been treated, and that can cause failure to thrive in young infants, for example. So it doesn't have to be something really serious or severe like disseminated tuberculosis or HIV. Even something as simple as a urinary tract infection that doesn't get treated because a young infant doesn't show signs of a UTI can lead to failure to thrive. So think about, could it be primary malnutrition? Could it be a chronic illness or an acute illness that's not been adequately treated? Or could the child have some genetic or syndromic cause? And by that, I mean, there's obviously some clinical genetic syndromes that are associated with failure to thrive, but then some children, of course, can have a propensity to being smaller, growing less, having short stature, etc. And so that based on their genetics from their parental height and their parental size. But generally speaking, if a child's failing to thrive, they've either got primary malnutrition or a chronic illness or some sort of genetic or syndromic cause. But that's not the physiological mechanisms. And I want us to consider also the physiological mechanisms by which children will have failure to thrive, because it helps us understand the type of history we should take and the examination findings we should look for. And so some children with failure to thrive will be just because they've got inadequate energy intake. So inadequate energy or calorie intake. For some, it'll be inadequate absorption if they've got gastrointestinal disease where their bowel is not absorbing nutrients. So inadequate energy intake, inadequate absorption, or increased energy utilization. So for some children who've got a chronic inflammatory condition, whether it's chronic tuberculosis or HIV or some chronic osteomyelitis, they will have increased energy utilization. Right? And so no matter how much energy they take in, it still won't be enough. And then for some, there's psychosocial factors, environmental factors, or factors at home, or issues with caregiving by a parent or maternal depression. So often in children with failure to thrive, whether they've got primary malnutrition or a chronic illness or a genetic syndrome, there will often be one or more of these factors going on. There'll always be one at least, but usually there's more factors, such as a combination of inadequate energy intake or inadequate absorption from their bowel, or increased energy utilization, or psychosocial factors. And for many children, there'll be all 4 factors in some way going on as part of the etiology of their failure to thrive. As I say, there's often multiple contributing factors to failure to thrive, and it is important that we try to understand what the factors are, that don't just it's easy to call it SAM or severe acute malnutrition, but try to understand the underlying factors. Failure to thrive has a big impact on development, and as I said, the notion of severe malnutrition and the developmental consequences of that are very important for us as paediatricians to understand and to take account of. I've put in this table, this is a complicated table, but I've put in this table those 5 different physiological mechanisms. So inadequate energy intake, inadequate absorption, increased energy utilization, a genetic or syndromic cause, and then psychosocial factors. And I've put in each of the lists of underneath inadequate energy intake, the types of reasons why children might have inadequate energy intake. For example, many babies have breastfeeding difficulties, or the mother and the baby have difficulty breastfeeding, and that might be due to a range of factors as well. Either there's an inadequate energy breast milk supply, or the mother's unwell, or there's a problem with attachment, a whole range of things. We often find that children fail to thrive not in the first 2 or 3 months of life, but often after about 3 or 4 months of life, and sometimes 4 to 6 months, then the growth curve starts to fall off. And usually that's because of inadequate complementary feeding. And so we know that excuse me. Level 1, healthy. 107. We know that if children if mothers have an adequate breast milk supply and the baby's sucking well, then that will be sufficient nutrition for the first 6 months of life. But beyond that, it's not sufficient nutrition, and the babies need complementary feeding. And one of the biggest problems, I think, in undernutrition in PNG and the Pacific is inadequate complementary feeding. Often it's reduced volume of feeds, so babies may only feed 2 or 3 times a day, or and only small amounts. So the reduced volume of feeds or reduced number of feeds. Often it's a lack of dietary diversity. So the babies will be fed just fruits and pawpaw and mashed bananas, and that may be all the baby's fed, or predominantly what the baby's fed. So this whole idea of inadequate complementary feeding is very important for undernutrition in babies in PNG. Not so much whether or not babies are breastfed at the time of birth, because the vast majority of babies are breastfed at the time of birth, but the reduction in breastfeeding that occurs over the first 2 or 3 or 4 months of life, followed by inadequate complementary feeding, is the major cause of undernutrition. Sometimes there's prolonged exclusive breastfeeding, that is, babies are not given any complementary feeding after the age of 6 months, and we know that means inadequate nutrition. And then sometimes children will have inadequate energy intake just because of anorexia. They're just not hungry. And if they've got a chronic illness, for example, if they've got tuberculosis or HIV and they're on antiretroviral drugs that make them feel nauseous or give them abdominal pain because they've got some abdominal TB, then the anorexia of chronic disease is a potent cause of inadequate energy intake. And then sometimes babies will have structural reasons like a cleft palate where they just can't suck no matter how good the mother's milk supply is, for example. And then occasionally in bottle-fed babies, there'll be errors in infant formula dilution. In fact, it's not occasional, it's quite common, isn't it? When babies are being formula fed, often there's errors in dilution of formula. So that can lead to inadequate energy intake because the baby's not getting enough calories. And then there's The next mechanism is if there's inadequate absorption of calories and protein and nutrients from the gut, and that can occur if children have chronic diarrhea, or this concept of environmental enteropathy, where because of exposure to lots of enteric pathogens, lots of Enterobacteriaceae and Klebsiella, that can change the bowel flora that children have in their gut, and that can lead to chronic or persistent diarrhea and malabsorption. And so this condition that occurs in children that have malnutrition of environmental enteropathy is actually quite an important cause of ongoing malnutrition, and one of the reasons why, despite providing enough calories, often children with severe acute malnutrition or severe chronic malnutrition may not gain weight, because they have environmental enteropathy, a change in their bowel flora and inadequate absorption. Sometimes also it'll be because of helminth infestation in the bowel, or rarely from celiac disease or cow's milk protein intolerance, which is relatively common. That is, some children have a mild allergy to cow's milk protein, and if they're transition from breast milk to cow's milk, any type of cow's milk, they may have some sort of chronic malabsorption syndrome, and then chronic inflammatory bowel disease, and sometimes children have antibiotic-associated diarrhea or even immunodeficiency, whether it's HIV or primary immunodeficiency, can all lead to inadequate absorption of nutrients and calories and protein, and that can lead to failure to thrive. And the third physiological mechanism is increased energy utilization. That is, the body needs more energy but can only get the normal or a reduced amount of energy. And so if children have a chronic illness like tuberculosis or HIV, they sometimes will have increased energy utilization, but at the same time they'll often have reduced energy intake and sometimes inadequate absorption. But as I said, even relatively mild infections, such as a urinary tract infection, can lead to failure to thrive because of either increased energy utilization or because the baby feels unwell and doesn't feed as well as what they need to. So always think, if a child's failing to thrive, make sure they don't have something simple like a urinary tract infection that's gone undiagnosed. Then, of course, children with congenital heart disease, they'll have increased energy utilization because they'll be more tachypneic, or they'll have tachycardia, and that just uses up a lot of energy. And sometimes, when in children with congenital heart disease that have tachypnea and tachycardia, they'll have reduced perfusion of blood to their bowel, and therefore they won't absorb as much energy. So there's multiple factors involved in failure to thrive in children with congenital heart disease, for example. And then rarer conditions, but still increased energy utilization occurs in hypothyroidism and diabetes, of course. And then the less common mechanism of skeletal dysplasias, or some chromosomal syndrome, you need to just examine the child and see if they've got any syndromic features, dysmorphic features, etc. And then probably one of the most important aspects is to really understand the psychosocial factors that are behind this child's failure to thrive, and it's not always easy, and you can't do it just in a half-hour or 1-hour consultation with the child or seeing a child on a ward round, but you often have to go back and talk to the parents about what's going on at home and what the environmental circumstances are. But certainly we see a lot of children with failure to thrive because of adoption or because of neglect. Sometimes there'll be other factors in the family, like domestic violence. Sometimes the infant will be an orphan, or the parents will be unwell themselves, or sometimes the mother will be depressed, or there'll be often a poor parental understanding of nutrition. They won't know that you've got to feed the baby more than 2 or 3 times a day, for example. They'll have an inadequate understanding of complementary feeding, or they may not know how to properly make up infant formula if the baby's formula fed, for example. So you need to go back and really understand whether or not the parents have a good understanding of nutrition. And then there's poverty, and sometimes there'll be attachment issues as well, where if there's a lot going on in the lives of parents, they may not be as nurturing for their infants. So there's all these factors that can be involved in severe acute or severe chronic malnutrition and lead children to fail to thrive. I don't expect you to remember all of those, but I think it's important, it's useful if we have a more detailed understanding of why children are failing to thrive. In terms of the identification, I think we need to understand when there should be red flags, so that we don't only diagnose failure to thrive when children have severe acute malnutrition. That's far too late, and it's very hard to retrieve the situation after that. When a child's failing to thrive, their weight gain is affected first, but if the problem persists, then their length is also affected. Wasting occurs before stunting, and then if that continues, then the head circumference is also affected, and the child's head will not grow. Now, sometimes this the head circumference, the slowing of the rate of growth of the head the child's head can occur relatively earlier. So it is important that we measure weight and length and head circumference whenever we are concerned that a child is failing to thrive. But if we see a child with a weight for age that's crossing centiles, and often that starts to occur around about 3 or 4 months when breast milk supplies are waning and complementary feeding is maybe introduced quite early, or beyond 4 to 6 months when complementary feeding is introduced and there's inadequate volume or inadequate numbers of feeds, or some problem with the complementary feeding, then the weight will be crossing centiles, and that should be a red flag, so that we don't only detect failure to thrive when there's severe malnutrition. If a child's losing weight, then that's much more concerning, of course. And if there's developmental delay, that should be a red flag as well for the failure to thrive. So I like to, on growth charts, I think it's useful to not only plot out the weight, put a cross where the weight is at different ages, but also say what's happening at that time. So I think if a child has a hospitalization, then that should be written into the weight chart. So this child was, you can see, was hospitalized for hospital admission for 5 days with diarrhea and fever. And that was at 8 months of age. And at 8 months of age, this child had already started to cross centiles. All right. And so there had been, in fact, the baby was preterm at 35 weeks gestation. That's the first significant milestone. And then complementary feeds were commenced at about 4 months of age, so a bit early. And you can see that by 8 months of age, the child had a hospital admission for 5 days, and then a hospital readmission for malnutrition and diarrhea and cough at 2 years of age. And this child with malnutrition with failure to thrive really should have been picked up at 8 months of age, and it should not have had to wait until the child was 2 years of age. And that's where we need to be identifying those red flags a bit earlier. And I do think it's helpful if you write in the hospital admission, so that hospital admission or presentations to hospital or significant illnesses the child has, because then you can understand what's happening at these different time points when the weight is being taken. That can be useful. Otherwise, you have to go back and look in the infant record book and find out what the illness was. Why did the child present at that particular time? But if you write it in the growth chart, just a simple one line in the growth chart, then it can be helpful in understanding what's happening at that time. We should be measuring head circumference more often, because sometimes that can give you again a red flag to failure to thrive and also developmental problems. And this child, this was a small girl who had head circumference measured, but you can see there's somewhere around about 8 months of age, she was crossing centiles with her head circumference. A lack of head growth really signals a very dangerous situation, and so we should try to measure head circumference whenever we do the other anthropometrics. In infants, it's good to check for overlapping cranial sutures too. And sometimes if up to sort of 6 or 8 months of age, if the head's not growing, then the cranial sutures will overlap, and it will be evident that the child's brain is not growing, and that often represents chronic undernutrition. When we're taking a history, so that's how to identify failure to thrive from the anthropometrics or the mid-upper arm circumference or some other trigger. But we need to know how to take a good nutritional history. And there's 3 parts to it, I think. The first one is a longitudinal history. So longitudinal means like along a timeline. And so you should always take a history from the time of birth. And so to find out what was happening around the time of birth, whether the baby was well at the time of birth or unwell, whether the baby had any signs of birth asphyxia, which might lead to poor attachment or poor sucking, or whether the baby was preterm, which might result in the same things. So you need to ask about the initiation, the frequency and the duration of breastfeeding, and what the mother thinks about her own supply, for example. A whole range of issues around the initiation and the duration of breastfeeding that the baby's had, and then the age at which complementary feeds were introduced. And so again, to chart some sort of timeline of nutrition is important. So a longitudinal nutritional history is important, but also important is a cross-sectional nutritional history. And so I usually ask, in a typical day or a typical week, it's often more important to say, in a typical week, what does your child eat? And it gives you an understanding of how much, particularly how often the baby is fed, how the volume of feeds, whether the child has their own plate or whether they share a plate with someone, another child. How many days a week does the child have a source of protein, for example? That's very important, because many infants and children, older infants and children, really live on a diet that's predominantly fruits and vegetables rather than having any protein as well. And if that, for some families, it can be useful to have a 3-day feeding diary where you ask the parent to record everything the child eats for over a 3-day period or a week. That can help you understand just how much of a balanced diet the child receives, and to what degree there's adequate dietary diversity in the child's diet. So those 2 things are a chronological or a longitudinal history, and then a cross-sectional history, which is like how much do they eat in a typical week. And then a systems review, which is partly focused on nutritional issues that can disrupt nutrition. So if a child's got vomiting or diarrhea or signs of malabsorption or abdominal distension, then it's likely that those things may disrupt nutrition. And then other things that might indicate a chronic illness that can lead to increased energy utilization or anorexia or reduced absorption from the gut, such as if a child's got cough or fever or lethargy or irritability. These symptoms, you need to take a full systems history to understand whether or not there's any other system factors that might lead to undernutrition. When you're looking for the signs of malnutrition on examination, we're all familiar with these, I think, but we look for, particularly for muscle wasting. So look particularly in the thighs and the buttocks, where there's often wasting of muscles. Look for edema, especially the feet and the hands. You can see this baby has very prominent ribs, and that's just because of, it's not because he's got chest indrawing, but because the baby's got intercostal muscle wasting. And you can see the intercostal muscles usually fill the ribs out, so you don't actually see the ribs so much. But when you've got the ribs being very visible, that's because of intercostal muscle wasting, and it's usually an indication that the child's got generalized muscle wasting. Measure the MUAC, the mid-upper arm circumference, and often children with severe malnutrition, of course, have other clinical features too, such as sparse hair or depigmentation of the skin, or they may have what looks like a very bony face. That's just because they've got subcutaneous tissue wasting, and it's just another manifestation of wasting. Look for dysmorphic features that might indicate a clinical syndrome. And then I think it's useful to make some assessment of the child's mental state, because most children who are failing to thrive will have some psychosocial delay. And so look to see what the interaction is with the mother or the father. Look to see if the baby or the child makes eye contact, or if they have withdrawn behavior or hypervigilance. Sometimes some babies have hypervigilance where they're really scared all the time, or whether the child looks like they have anxiety. I mean, all of these features are quite common in children with failure to thrive, especially older children who've been either neglected or not been given adequate calories. And then look for evidence of chronic disease, and look for signs of immune deficiency. So candidiasis or lymphadenopathy or hepatosplenomegaly, you need to look for those things. And then it's useful to, at the same time as you're assessing the child's mental state or their psychosocial situation, then I find it useful to have to observe the child feeding, and to see whether the child's actually interested in feeding, whether they demand food, what their techniques of feeding are, and whether they can coordinate a suck or a swallow. And sometimes it's useful to even video the child feeding, just to see if they seem to have normal mechanisms for eating. And it's also partly that you're observing the interaction between the mother and the child, or the parent and the child, while they're feeding, and then do a developmental assessment. And when you're assessing a child's development, then the aspects that are affected by failure to thrive are all the aspects, whether it's the gross motor function or the fine motor function, less so the vision and the hearing, but the socialization is often very affected. So when you're assessing to see if a child's got developmental delay associated with failure to thrive, then particularly look at the gross motor function. So they'll often have poor muscle bulk and poor tone that will usually be generalized, or they may have weakness or immature truncal posture. That is, a child who's 12 months of age may have trouble sitting by themselves, whereas of course they should be able to sit by themselves without support at 6 to 9 months of age, or they might have head lag because of muscle wasting. And as I said, the assessment of the mental state of the child is very important. So look for these signs of apathy or irritability or anxiety or depression. We sometimes don't look for these things in children. We assume that those psychological features only occur in older children or adults, but actually they certainly do occur in infants and young children with failure to thrive. Some neglected children will withdraw from social contact. That's different to stranger anxiety, but many stranger anxiety is a normal thing, so it's not a feature of neglect, but it's often a feature of just being normal developmentally. But if an infant withdraws from all social contact, especially with the parents, then that can be a sign of something serious going on. Often they'll have, gaze aversion, so they won't look the parent in the eye, or they'll have a lack of interest in the social overtures that a mother or another adult shows to the child. So this assessment of the child's mental state becomes very important. You can see these are pictures of the same infant who had severe malnutrition and then was fed, and you can see the difference. The child from the malnourished state, where the child's very apprehensive, where they've got muscle wasting, intercostal muscle wasting, and they don't look at all happy, to the well-fed state of this child, where they're smiling and they're happy. You can see the difference that good nourishment makes to the mental state of the child, and this is important for us as paediatricians to appreciate. I said the domains of development before, so we need to assess the gross motor function, the fine motor function, the vision and the hearing and the socialization. And when you're assessing gross motor function, then it's the head and truncal control, whether they can roll or not, whether they can sit. So babies should be rolling at about 4 months of age. They should be sitting at 6 to 9 months of age. They'll be often pulling to standing at 10 to 12 months of age. They may be walking at 12 to 14 months of age. And so we need to have an understanding of those gross motor milestones. And to do that, I think it's useful to have a chart that's a bit like this. There's many different charts that you can use, but this is, I think, a good one where for the child, at any time you see the child, you can just circle the activity that the child, the activity that they can do best, right? So the most advanced activity they can do in terms of head and truncal control, the most advanced activity they can do in terms of rolling or sitting or crawling and walking. And these are all the gross motor functions. And then arm and hand control, you can circle the activity they can do best in that domain in terms of arm and hand control, which is really fine motor skills. And then hearing and vision, you can circle the activity they can do best. And that can give you, when you do that, if you have a chart like this for each child, every time you see them, you can see where they're up to in terms of their gross motor, fine motor, vision and hearing and socialization. And I think that having a chart like this can be very useful. I've talked a bit before about the child-parent interaction. I won't say too much more about this, but when you're watching a child, you need to know, do the parents appear to engage, do they appear to enjoy looking after the child, or are they frustrated, or are they disengaged? Are they coercive? Do they try to force feed the child? Do they seem upset or frustrated, the parents? Do they handle the child gently or roughly? And do they make eye contact and play with the child, or are they just too distracted or busy or upset to do that? And so one shouldn't make judgments about parents, but it's important to make observations about the quality of the parenting and the social interaction, because that will often be a factor in children who are failing to thrive. And I think it's something we often don't do as much. We consider only the physical aspects of severe malnutrition, but it's in any case of failure to thrive, an in-depth or some sort of psychosocial evaluation is necessary, I think. When you've got children with failure to thrive and you've done a full examination, if you found no signs of organic disease, like no symptoms or signs of cough or fever or malabsorption or abdominal distension or hepatosplenomegaly or immune deficiency, then often investigations have a very low yield. And so, and that's because if you do a full examination and find no signs of physical disease, then the majority of cases of failure to thrive have a non-organic cause. That is, they're due to inadequate energy intake or inadequate energy utilization rather than a physical illness. But I guess where TB and HIV are very common, then it's important, even if you haven't got signs and symptoms, if you have a child with severe failure to thrive, to rule out TB and HIV. And that can often be done on the basis of clinical signs and symptoms. And if you've got a child with severe malnutrition, then ruling those conditions out is very important. As I said, there's a couple of hidden organic diseases that may cause failure to thrive. And so I think it's mandatory that you should check the urine and make sure that the child doesn't have a UTI, because you won't be able to detect that by clinical signs and symptoms in most children. We know that the management of all sick children can follow the same stages of management. And so we need, in any sick child, we need to do triage and emergency treatment if needed, then take a proper history and do an examination, like I mentioned, and then any laboratory investigations based on the history and the examination if they're required, and then come up with the main diagnosis and other diagnoses, and then decide on your treatment and supportive care and monitoring and the child with severe malnutrition, you need to do the same thing. Thanks. You need to follow the same course. A child with severe malnutrition, you can follow the same stages of management. But there's also the specific ways in which we manage severe malnutrition, and that this is contained also in the Hospital Care for Children book. And there are many different phases of management of children with severe malnutrition. I won't go through all of these today, except to say that in the first couple of days of management, there are certain risks like hypoglycemia or hypothermia or dehydration, and you need to be really attuned to those risks. And then later on, thinking about electrolyte replacement and infection and the other stages. So there's a stabilization phase where you need to be considering all of these treatments: the prevention of hypoglycemia, the prevention of hypothermia, the correction of dehydration, the replacement of electrolytes, the treatment of infection if it exists, the giving of micronutrients, initiation of feeding, very important in the first few hours of treatment, and sensory stimulation. And then later on, after the first week, then some things become less important, and you're really more focused on catch-up growth and trying to get the child to grow. This is the WHO plan for the management of children with severe malnutrition. I won't talk too much about that today because we'll have another lecture where we talk about severe malnutrition and its complications specifically. But I wanted to just outline that and talk a bit about this condition that we don't talk much about, which is refeeding syndrome. And when we have a child who's failing to thrive, or we have a child with severe acute malnutrition, when you start to feed the child, then certain things happen. And sometimes we might see a child with severe malnutrition who comes into the ward and they start feeding, and within 24 or 48 hours they've deteriorated. And there's a reason for that, and I want to try to explain that. Sometimes it can be because of an infection the child has that brought them into hospital that's not being treated adequately, but sometimes it can be because of this problem called refeeding syndrome. And this syndrome was first described in just after World War II, when in 1945, people who'd been living for years in concentration camps during World War I were often very starved. They had severe malnutrition, and when they were fed, when they were given adequate amounts of food after being released from the concentration camps, then many of them got diarrhea and heart failure and convulsions, and they deteriorated severely. From being severely malnourished, they became severely unwell. And it's now well understood why that happened. And it does sometimes happen to our children with severe acute malnutrition when we first start feeding them. And the reason, I just wanted to go through the physiological mechanism for refeeding syndrome. And this is a little bit complex, but it's useful to try to understand it. And when there's a state of severe malnutrition, so if you think about the children we see with severe malnutrition, they have reduced, because their energy intake is very poor, then their insulin production is really suppressed. And so they are in a state all the time of catabolism, right? That is, their body's constantly breaking down to make energy so that their organs and their body can survive. And so instead of being in a state of anabolism and growth, anabolism is like where your body is building up in it, using energy to build up protein and build up fat and build up strength and cartilage and bone, then their body is constantly breaking down to make the energy they need to simply survive, because there's not enough energy available. So they have very high glucagon and cortisol levels, the stress hormones, and that leads to glycogenolysis, which means all their glycogen stores in their liver are being broken down to glucose, and their body will break down protein. So that's why they have muscle wasting, is because the body, there's lots of protein breakdown, and that leads to muscle atrophy and low levels of protein in the body. So if you measure the child with severe acute malnutrition's albumin level, like that's one of the proteins, they'll often have very low albumin, and their immunoglobulins, which are just proteins but they're important for immune function, they'll be very low too. So the child is constantly breaking down glycogen in the liver, they're constantly breaking down muscle, they're breaking down their lipid stores, so their fat stores, and they invariably have electrolyte depletion and vitamin depletion. So that's what happens during this, on the right side of the diagram. That's what happens during stages of severe malnutrition. And if you take a child with severe malnutrition, and then you refeed them, you start feeding them, then that seems like a relief. But they switch quite quickly to anabolism, which just means building up of protein and building up of muscle stores and fat stores. And it means that they then have marked increases in insulin secretion, which leads to glycogen synthesis in the liver. It leads to increased protein synthesis and to build new muscle. But that requires a lot of electrolytes, and it requires thymine to be taken up into cells. And so there'll be when you have a marked insulin secretion, then you'll have increased glucose uptake into cells and lots of potassium moving into cells and magnesium and phosphate all being taken up into cells for this anabolism, for the creation of new tissue, of muscle growth, fat stores, and etc. And what that can do is lead to all of these things, thymine and glucose and potassium and magnesium and phosphate, are being taken up into cells, and they can be depleted from the bloodstream. And so these children can often have hypokalemia or hypomagnesemia, their magnesium is low, or their phosphate is very low in the blood, or they'll have thymine deficiency, or they'll have salt and water retention. That is, their body is retaining too much salt and water. And all of those things can lead to clinical complications like cardiac arrhythmias or hypotension, or generalized weakness if they've got low phosphate and low magnesium, or reduced cardiac function, or edema and kidney failure. And so these are the downstream effects of refeeding syndrome. And the reason is because the body is trying to switch from catabolism, where it's constantly breaking down, to anabolism, where the body's building up muscle again, but often doesn't have the electrolytes to supply it. So that's what happens in refeeding syndrome. I won't go through this again, but this explains it in some more detail. Catabolism is starvation, and that's where you've got reduced insulin and high stress hormones, glucagon and cortisol, and your body is constantly breaking down protein and fats and mobilization of liver glycogen until it's depleted to form glucose to make the energy, that is ATP, adenosine triphosphate. That's the energy that all our cells need, and that depletes potassium and phosphate. And when you get anabolism, you get increased insulin secretion. So when you start refeeding, and that leads to healthy protein synthesis and glucose storage, but it drives glucose into cells. It depletes the blood of potassium and magnesium and phosphate and thymine just to make the protein. And so you then have low levels of that in the bloodstream. And that is what caused these children to have refeeding syndrome and diarrhea and heart failure back 60 years ago. And people have only, understood why afterwards. But that refeeding syndrome was a a common cause of deterioration and sickness in patients after World War II, and is often a cause of the deterioration in patients after they present with severe acute malnutrition. So the way you can prevent it is to replace enough potassium, phosphate, and magnesium and thiamine as during the refeeding of children with severe malnutrition. And so the WHO guidelines for severe malnutrition recognize this risk of refeeding syndrome, and that's why the F75 is a low carbohydrate and low protein formula to begin with. And so that means that there's not so much insulin production to start with. And F75 also has added supplemental potassium and magnesium and phosphate. And we know that if a child's got refeeding syndrome, then sometimes their heart function is a bit weaker. And so we need to avoid fluid overload in those children. So that's why we shouldn't give maintenance intravenous fluids to such children. It's much better to be giving enteral feeding and enteral rehydration if they're dehydrated, but making sure they've got adequate amounts of potassium and magnesium and phosphate to prevent the consequences of refeeding syndrome. When in children with who are malnourished, often they'll have a different Starling curve. You're familiar with the Starling curve for heart function, and that is, if you've got normal heart function, then as you increase your left ventricular end diastolic pressure, that is the volume in your heart, then that increases your contractility of your heart. But if you've got a weak heart muscle because of muscle atrophy from severe malnutrition, or because you've got hypokalemia or hypomagnesemia or hypophosphatemia, then as you increase the volume load on your heart, then the stroke volume doesn't increase and the cardiac output doesn't increase. And that can lead to cardiac dilatation, dilated cardiomyopathy that's associated with malnutrition, and it can lead to heart failure. And it doesn't usually if you don't give children intravenous fluids, but if you give them, if children are severely malnourished and you give them their normal maintenance fluids, or you give them large boluses of fluids, then that can lead to heart failure. That is, despite the increased volume load on their heart, their stroke volume doesn't increase and they can go into heart failure. I wanted to just briefly talk about Thymine, because it is very important. And I said before that when you are in an anabolic state, that is, you're starting to, your cells are starting to make new protein and store glycogen again and metabolize by making new ATP, then Thymine becomes very important. And if a child is Thymine deficient, then they won't be able to make protein, because Thymine is very important in the manufacturing of protein through RNA synthetase. And you won't be able to manage the Krebs cycle, which is the cycle that gives us energy. Gives all our cells have the Krebs cycle that generates ATP, or adenosine triphosphate, and that produces energy. And thymine pyrophosphate, or just think of it as Thymine, is involved in both the entry into the Krebs cycle and also the Krebs cycle itself. And if you don't have Thymine, if the child's Thymine deficient during a time of refeeding particularly, but in children with severe malnutrition, then the pyruvate that gets produced will get converted to lactate, and that can lead to a lactic acidosis. And so I won't talk about this too much, but Thymine is very important in the prevention of lactic acidosis and in the production of protein and in the normal Krebs cycle that all cells undergo to create energy. And so Thymine, in children who are Thymine deficient, they won't have enough Thymine to make new protein. And so even if you feed them adequately with enough carbohydrates, if they don't have Thymine in the carbohydrates, then they won't make new protein, and they won't be able to generate energy because Thymine's a cofactor in the Krebs cycle. And so instead of the Thymine entering the Krebs cycle, it gets pyruvate gets converted to lactic acid, and then the child becomes has a lactic acidosis. And so if you only give glucose in a child without Thymine, who's Thymine deficient, if you only give glucose, then what happens is the glucose gets converted to pyruvate and then to lactate, and it never gets converted to protein, and it never gets converted to energy because of a lack of Thymine. So we need to think about we need to think in children who are severely malnourished that they have enough Thymine. They need enough potassium and magnesium and phosphate and glucose, but also enough Thymine to prevent lactic acidosis. And there's probably a link in children who are severely malnourished with pulmonary hypertension and malnutrition and hypoxia and heart failure. All of these, sometimes you see children that their pulmonary hypertension, their pneumonia, their malnutrition, their hypoxemia and their heart failure can be corrected by not only treating their severe acute malnutrition, but also giving additional Thymine. F75 has Thymine in it, but if you're just using, if you don't have F75 and F100 and you're just using cow's milk powder formula, then that doesn't have Thymine. It doesn't have an adequate amount of Thymine in it, and that's when children will become develop refeeding syndrome and Thymine deficient, and it puts their heart under more strain. So some children are more prone to Thymine deficiency than others. So breastfed babies of mothers who are Thymine deficient, I mean, if a mother's severely undernourished, then their child may be Thymine deficient. If Thymine is present in the outer covering of rice, and if parents wash their rice before they feed their child, then the child may be Thymine deficient. And some food substances have an anti-Thymine activity. So betel nut particularly has an anti-Thymine activity. And so if a mother washes rice and chews a lot of betel nut and their children are malnourished, then it's quite likely that the child will be Thymine deficient. And when you refeed them, then they'll need a source of Thymine as well as a source of glucose and potassium and phosphate, etc. Okay, so I'm just about to finish now, and I thought it would be useful to talk today about the identification and management of children with failure to thrive. And this is just an overview. There's a lot more that could be said about severe malnutrition and failure to thrive, but I wanted to give you a holistic view of the subject. And remember to identify the causes and try to understand the mechanisms of failure to thrive. Follow the stages of management that WHO has set out in the guidelines. In the Hospital Care for Children book and in our standard treatment book, the management is very clear. Be aware of refeeding syndrome and be aware of the mechanisms of refeeding syndrome and what you can do to prevent it. And then I think for children with severe malnutrition, we need to establish a feeding pattern in hospital that can be reproduced at home. So it's pointless feeding them only hospital-based food, but important to try to understand what the parents can do at home and try to reproduce that in hospital if you can. I think children with severe malnutrition need a written feeding plan. You should do that for children, both for their hospitalisation, but also after they go home. The discharge planning for children with severe malnutrition is very important. And most parents, most mothers and families need some sort of psychosocial support when they're being discharged and during their hospital stay, because often the mothers will be depressed as well if they've got a child who's got severe malnutrition. The children need follow-up for their growth and development and vaccines and sometimes behavioural problems or whatever. So you need to keep following up these children for a long time until they're thriving again. So I've tried to describe today a holistic approach to failure to thrive that's a bit more than just the 10 steps of management of severe malnutrition. And I hope that's been useful for you today. So I'm going to stop there and happy to answer any questions. Right. Thank you.